Hello, dear colleagues. First, I would like to thank the organizers for giving me the opportunity to present at the ITSAPA Congress. The title of my talk is The Impact of Antiphospholipid Antibodies in Childhood Onset SLE. These are my disclosures, but none of those relate to this presentation. And in this presentation, first, I would like to provide a brief background, particularly on the genetics that somehow gives us insight in the pathogenesis of SLE and antiphospholipid syndrome. Then I will briefly present prevalence of antiphospholipid antibodies in childhood onset SLE and some impact on disease activity and damage. And then I would like to focus on studies in antiphospholipid syndrome in childhood, where I will focus on autoimmune related antiphospholipid syndrome. And in the last part of my talk, I would like to present some data from the cohort studies in childhood onset SLE patients, focusing on aPL related manifestations. I would like to particularly somehow highlight the question whether the manifestation is related to antiphospholipid antibodies or could be related to childhood onset SLE activity. First, a few words about childhood onset SLE. The disease is extremely rare in younger than 9 years. So most of our patients are teenagers, as you can see on this table. And if we look at the monogenic causes of childhood onset SLE, we can see that this disease is really heterogeneous. It is not a single disease, but are more than 100 diseases with common clinical presentation. The most common groups that cause SLE in children, let's say the monogenic causes of SLE in children, are complement deficiencies, genetic overproduction of interferon alpha, apoptosis defects, or defects in adaptive immunity or metabolic pathways. On this slide, you can see a nice review of published cases on monogenic lupus in children. You can see that the most common are apoptosis defects. One of those are DNase 1L3 deficiency. We have 4 patients with this deficiency. Type 1 interferon disturbances, defects in adaptive immunity, such as protein kinase C delta, and some pathways of metabolic disturbances. So you can see the wide heterogeneity, and this heterogeneity in pathogenesis of SLE somehow reflects also with the clinical features of this monogenic SLE, as for example, the apoptosis defects particularly present with renal disease, while interferon disturbances more commonly present with some CNS involvement in these patients. On this slide, I would like to somehow combine the data from monogenic SLE with the data that we know on the genetics of antiphospholipid syndrome. We know that there are several susceptibility genes, as shown on this figure. The thickness of the line somehow relates with how strong this association with APS exists. And you can see that with APS, most susceptibility genes were related to the immune response. So you can see that this wide heterogeneity of SLE and APS somehow definitely results also in the heterogeneity of this combined disease. I do not have time to go into focus for all these different pathogenic mechanisms, but I would just like to highlight the complexity, for example, of the interferon signature in SLE and APS patients. As you know, SLE is a typical disease with increased interferon signature, as shown on this figure. Also, patients with SLE and APS, not surprising, have increased interferon score, but also patients with primary APS without underlying SLE have higher interferon score as healthy controls. And for these patients with primary APS, the interferon score is significantly higher in patients with positive ANA, and kind of a very encouraging. We treat all our patients with APS and SLE with hydroxychloroquine. Hydroxychloroquine can somehow decrease this interferon signature. Why I'm showing this data, our center is also somehow interested in STAT signaling in patients with childhood onset SLE and pediatric APS. The study that we published a couple of years ago in Journal of Rheumatology, focusing on STAT signaling, showed that patients with SLE and pediatric APS had higher expression of STAT1 and STAT5, as you can see on this slide, comparable to healthy control. Particularly patients with childhood onset SLE had higher basal phosphorylation of STAT1. What was somehow striking, comparable to healthy controls, was that upon stimulation with interferon alpha, there was no response or significantly lower response as compared to healthy controls in patients with SLE as well as in patients with pediatric APS. So in patients with APS and SLE, there is definitely a significant overlap also in some pathogenic mechanisms, and it is difficult to somehow evaluate and combine these two such a heterogeneous diseases. On the next part of my talk, I would like to focus on prevalence of antiphospholipid antibodies in children with SLE. As you can see, compared to some other diseases, like, for example, juvenile idiopathic arthritis or other autoimmune diseases, patients with childhood onset SLE are a pediatric population that has the highest percentage of aPL positivity. And of course, patients with APS have aPL positivity as part of their diagnostic criteria. And on this slide, you can see somehow comparison of different studies that evaluated only antiphospholipid antibodies prevalence in patients with childhood onset SLE. The most common are anticardiolipin antibodies, which are frequently reported in more than half of all children with SLE. Anti-beta-2-GP1 antibodies were not evaluated in all studies, but in our experience are present in approximately 1/3 of patients with childhood onset SLE, and lupus anticoagulant also in approximately 1/3 or 25% of patients with SLE in pediatrics. These are data from a large Brazilian cohort that are following almost 1,500 patients with SLE, pediatric patients with SLE, and among those, 67 had antiphospholipid syndrome. I found this data very interesting. They evaluated a comparison patients with APS and without APS, and found no differences in disease activity as assessed by SLEDAI index. But of interest, patients with APS had significantly higher damage. And this damage was mostly related to cerebrovascular involvement or neuropathy. So particularly stroke is one of the clinical manifestations that cause damage and needs to be somehow looked upon in these patients. On the next part of my talk, I will focus on antiphospholipid syndrome in childhood, and I will try to somehow focus on the lupus-associated activities. On this slide, you can see the general epidemiology of antiphospholipid syndrome in children. In general, if you look at the unselected children with thrombosis, antiphospholipid antibodies are found in approximately 10 to 25% of children with thrombosis. In most of these children, antiphospholipid antibodies are not the only risk factor for thrombotic event. There could be also other thrombotic risk factors, but these are somehow epidemiological data. In our kind of a country, we estimated the frequency of APL-related thrombosis, approximately 8.4 cases of definite APS per 100,000 live births. These are updated data from the pediatric APS registry. Currently, we have a follow-up data of 140 children with definite APS. The data that I would like to highlight, half of these patients had underlying autoimmune disease, and in 90% this was SLE. So almost half of the patients included in the pediatric APS had underlying SLE. You can see here the frequency of thrombotic events, and already with the analysis of data from pediatric APS registry, we noticed significant association with non-criteria features, particularly hematological, skin disorders, and some non-thrombotic neurological manifestations. These are data from Chinese pediatric APS registry, including 58 children with APS. In their cohort, the percentage of patients with underlying SLE was even higher. 69% of patients with APS had underlying SLE. On this slide, you can see somehow a summary of non-criteria features of antiphospholipid antibodies, and it tends to appear that these non-criteria features are more common in patients with APS who have association with SLE than primary APS patients. And some of these criteria particularly appear to be somehow associated with SLE. So these are hematological manifestations and neurological, such as cognitive impairment. These are unselected data from our center on APL positive children. So we evaluated as a follow-up all APL positive children, and from this unselected cohort, we found that 16% of patients had thrombosis, but all other patients were evaluated for antiphospholipid antibodies because of certain other manifestations, such as hematological, neurological disorders, or skin disorders, and 8% of our patients had recurrent thrombotic event. Non-criteria manifestations in a cohort of patients with APL were recently published also from Spanish centers. They evaluated possible association with SLE diagnosis, and in univariate analysis, it appeared that non-criteria manifestations are associated with SLE, but in multifactorial analysis, SLE diagnosis was not identified as independent risk factor for the presence of non-criteria manifestations in patients with antiphospholipid antibodies. Before moving to next section, I would like to present also two somehow more specific clinical manifestations. One is pediatric catastrophic APS. These are data from 45 pediatric patients included in the international CAPS registry, and 31% of these patients had underlying childhood onset SLE. And the other manifestation that I would like to highlight, and is particularly characteristic for children, is lupus anticoagulant hypoprothrombinemia syndrome. This was a nice review of 54 pediatric cases with lupus anticoagulant hypoprothrombinemia syndrome, which somehow presents with bleeding diathesis without thrombotic events, and 37% of published cases were associated with underlying SLE. In the last part of my talk, I would like to present the approach from the other side. So looking the data from a specific childhood onset SLE cohorts and what were somehow manifestations that were associated with antiphospholipid antibodies. I'm coming back to this Brazilian retrospective cohort of 1,519 childhood onset SLE patients. They observed APS in 4% of these patients. And what was of note, 58% of these patients presented with antiphospholipid syndrome. So in pediatric patients, in children with SLE that developed APS quite frequently is the presenting manifestation. The Brazilian multi-center cohort did not report so frequently non-thrombotic manifestations, present only in 31% of patients, and they reported livido reticularis and valvular disease. Among the thrombotic manifestations in the Brazilian cohort, you can see here the percentages. The most common was venous thrombosis, followed by arterial thrombosis. And to my knowledge, the Brazilian study is the only study that reported also pregnancy complications. There was one patient that had pregnancy complication, which is one of the most common manifestations in adult patients with antiphospholipid syndrome. Definitely in teenage patients or in young adult patients, we need to be aware also of pregnancy complications. These are the data from a nice review published a couple of years ago on annual thrombosis incidence rate in pediatric patients with SLE and positive aPL. And you can see here that the annual thrombosis incidence rate is approximately 5%. So if your patient with SLE has positive aPL, there is a 5% incidence annual rate of thrombosis. I think that this is kind of a mnemonic help that is useful for the clinical care. From the clinical care, I would just like to briefly share some of our patients. These are quite complex patients. A patient with venous thrombosis who developed 2 days after the thrombosis arterial rash, probably related to complement activation, but it is somehow an unusual manifestation. And of course, in SLE patients, you can expect all different rashes. So this was a patient with arterial rash. Of use clinical are also some newer imaging techniques. This is one of our teenage girls who first developed venous thrombosis, and after that developed inferior wall endocardial infarction, myocardial infarction. So she had actually venous and arterial thrombotic event. And this is one of our patients with digital gangrene associated with antiphospholipid antibodies in SLE, and with this kind of a thermographic camera showing the cold area in this digital gangrene area. In addition to thrombosis, the second strong association in patients with childhood onset SLE is with neuropsychiatric manifestations. Their children with SLE can present with a whole range of neuropsychiatric manifestations, as shown on this slide. And antiphospholipid antibodies were most strongly associated with focal manifestations, such as strokes, cerebrovascular accidents, but also with diffuse. So antiphospholipid antibodies are probably one of the autoantibodies that are most frequently associated with focal and diffuse neuropsychiatric manifestations in children with SLE. And this is a study where we included 137 children with childhood onset SLE from Canadian centers. They were followed up. And as you can see on this figure, we somehow established the whole range, the whole spectrum of neuropsychiatric manifestations in children with SLE, but the strongest association appeared with chorea and transverse myelitis. So the statistical analysis actually confirmed at the time of diagnosis, there was statistically significant association with cerebrovascular disease. And on a long-term follow-up, particularly with chorea, there were only 2 patients with transverse myelitis. Both had positive antiphospholipid antibodies, but the statistical analysis was not able with this a small number of patients, even if the study included 137 children with SLE. So this is a child with venous vein thrombosis and one child who presented with catatonia with basal ganglia involvement and highly positive antiphospholipid antibodies. Just a short note that one of the most difficult manifestations that we need to assess in pediatric patients with SLE is cognitive dysfunction. It is difficult to diagnose and treat. You must take into account that the child you must have to take into account the child development and changes with this development. So the cognitive dysfunction needs to be adapted to each age range. And of course, it can be very subtle and easily overlooked. So we need to somehow actively search for this. And this is also one of the presentation and that could be associated with antiphospholipid antibodies. I would just like to briefly share one of our patients with SLE who was who presented this choreoathetotic movement disorder. She had highly positive anticardiolipin and lupus anticoagulant antibodies. She was perfectly conscious but was unable to control her movements. Choreoathetotic movement disorder associated with highly positive antiphospholipid antibodies. She was aggressively treated with combination therapy, and actually after 10 days, she was actually able to significantly improve. She received combined treatment with IVIG, pulse methylprednisolone, and cyclophosphamide, and made a tremendous improvement. The last patient that I would like to share is a patient with transverse myelitis that presented with bilateral leg weakness and also had significantly highly positive antiphospholipid antibodies. So at the end of the clinical manifestation, I showed you the association with thrombosis, association with neuropsychiatric manifestations, particularly cerebrovascular accidents and chorea. The last clinical manifestation that I would like to present are hematological manifestations, and particularly autoimmune hemolytic anemia and antiphospholipid antibodies in children with SLE. This is a nice meta-analysis of 11 studies in more than 575 patients. Among those were 131 patients with childhood onset SLE. And you can see that this table shows the data from patients with SLE. You can see that the hemolytic anemia was strongly associated with positivity for IgG anticardiolipin antibodies with odds ratio of 3, and evaluation of SLE patients without APS and SLE patients with APS. You can see also association of hemolytic anemia with APS in patients with SLE in APS, and they also compared data with SLE and APS with primary APS, and those patients who had underlying SLE had higher incidence also of autoimmune hemolytic anemia. The last study which I would like to present is a Turkish multi-center study in 215 children with SLE, where they identified antiphospholipid antibodies and high SLEDAI as an independent risk factors associated with hematological manifestations and most commonly autoimmune hemolytic anemia. And you can see here the p-values that were only significant for these antiphospholipid antibodies and SLEDAI risks. So to conclude my presentation of the impact of antiphospholipid antibodies in childhood onset SLE, I initially presented that SLE is very heterogeneous disease, and in children it is severe, aggressive disease. Probably a lot of children have some underlying monogenic defect. We are able to identify some of these. Maybe in the future we will be even able to identify more. But for antiphospholipid antibody presence, I would estimate that at least 50% of pediatric patients with SLE have present aPL, most commonly anticardiolipin antibodies. And antiphospholipid antibodies were significantly associated, particularly with thrombosis, neuropsychiatric manifestations, and hematological manifestations. At the end, I would like to say that I believe that when we investigate these manifestations in patients with SLE, it's a combined contribution of both SLE pathogenic mechanisms and antiphospholipid antibodies, probably as an additional risk factor, or maybe second hit also for some of these manifestations. And of course, for certain of these manifestations, such as thrombosis, neurological manifestations, and hematological impairment, particularly autoimmune hemolytic anemia, we have somehow identified pathogenic mechanisms where antiphospholipid antibodies could be directly pathogenic. So thank you very much for your attention. At the end, I would like to thank our colleagues from the department and from the lab and some of our agency that helped in establishing our research. Thank you very much and enjoy the rest of the Congress.